Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. We will discuss obstetric case taking because this subject is too long, occupying about 60 slides. I prefer to divide it into two parts. Part one, including up to the end of history taking, and part two, including the rest of the subject. We'll start by part one. The content include introduction, the obstetric diagnosis with some terminology, history taking. These are included in the part one slideshow. The rest, clinical physical examination, including general examination, abdominal examination, obstetric maneuvers, and bedside urine analysis for sugar and protein, and finally some self-assessment quizzes. The science of obstetrics is a unique branch of medicine that deals with more than a human being at a time, namely the pregnant parturient woman and her fetus or fetuses. This character is unique for the branch, for this particular branch of medicine. It is an advantage to be an obstetrician whose job is observation of the absolute power of the Almighty Allah in creation and development of a human being just like yourself. We start with the objective. Our objective in obstetric case taking is to reach the complete obstetric diagnosis. What is the complete obstetric diagnosis? The complete obstetric diagnosis is the essential target for any student or practicing physician taking or dealing with an obstetric case. The items of this obstetric diagnosis include the following 9 items and should be mentioned at the end of case taking in sequence. We take the opportunity to discuss the obstetric case taking to define some terminologies to facilitate or to be familiar with this branch of medicine. Obstetric case taking include gravidity, parity, duration of pregnancy, fetal lie, fetal presentation, fetal position, engagement of the presenting part, disease in current pregnancy, whether pregnancy induced or pregnancy associated, medical or surgical, previous disease that may affect the management of the current pregnancy. So we have 9 items in the obstetric diagnosis which should be mentioned in sequence at the end of the obstetric case taking. We start with gravidity. What's meant by gravidity? Gravidity means number of pregnancies, including the current one. It does not differ whether that pregnancy was normal or abnormal. For example, if the patient had ectopic pregnancy, it is counted in gravidity. If it had a molar pregnancy, it is counted in gravidity. So gravidity means number of pregnancies including the current one, regardless its nature. What's meant by parity? Parity means deliveries. Definition of parity are those pregnancies that had been terminated after 20 weeks gestation. Pregnancies that had been terminated after 20th week gestation. It is not important whether this pregnancy was multiple pregnancy, singleton pregnancy, the fetus is dead, the fetus is alive, and so on. It only accounts for the number of deliveries or number of pregnancies that had been terminated after the 20th week gestation. The nature is not important in definition of parity. Duration of pregnancy, we usually, and other methods for calculating the gestational age, ovulation delivery interval, the expected date of delivery equals ovulation date minus 7 days plus 9 months. If the patient had single coitus, single known coitus, the expected date of delivery is calculated by subtracting 7 days from the date of that single coitus and adding 9 months to get the expected date of delivery. In cases of IVF, the expected date of delivery is calculated by knowing the date of embryo transfer, subtracting 5 days from that date and adding 9 months. The date of quickening from the history, usually we know that date of quickening is at 20 weeks gestation in primi gravida and is at 18 weeks in multipara. So, to complete this into the expected date of 40 weeks, in primi, we add 20 weeks to the date of quickening. In multi, we add 22 weeks to the date of quickening. We come to the fetal lie. What's meant by fetal lie? Fetal lie means the relationship between the long axis of the fetus to that of its mother. So we have three possibilities, only three possibilities. If the long axis of the fetus is parallel to the long axis of its mother, it is a longitudinal lie. If the long axis of the fetus is perpendicular to that of its mother, it is transverse lie. If the long axis of the fetus is in between, it is not perpendicular and not parallel, it is oblique lie. These are the three possibilities of the fetal lie. So we have longitudinal lie. We have the longitudinal lie is the most common, about 99% in cases. The transverse lie about 0.5% of cases. Oblique is not. It is very rare, and usually it is transient. It is transient lie. Okay. What about the fetal presentation? Fetal presentation means which part of the fetus is in relation to the pelvic inlet and first felt by vaginal examination. We have three possibilities for the fetal presentation. The first possibility, the fetus presents with its head, and this is called the cephalic presentation. Or the fetus presents with its buttocks, with or without the feet, and this is called breech presentation. And the last possibility, when the lie is transverse, the fetus presents with its shoulder. However, we should know that cephalic presentations are not a single presentation. It differs according to what's called fetal attitude. Let's say the fetal head, if it is fully flexed, or fully extended or midway between extension and flexion. This differs according to the attitude. So, when the fetal head is fully flexed, the fetal head part that presents is the vertex. The vertex here is the fetal head part bounded anteriorly by the coronal suture and the anterior fontanelle, posteriorly by the lambdoid suture and the posterior fontanelle, and laterally by two imaginary lines passing through the parietal eminences, and this is the vertex. The most prominent landmark, pony landmark of this vertex is the occiput. So we have the vertex presentation or occiput presentation when the fetal head is fully flexed. If the fetal head is fully extended, the fetal head part presents to the pelvic inlet is the face, fetal face, and so it is a face presentation. The pony landmark of the face is the fetal chin or mentum. If the attitude is between flexion and extension, the fetus will present with its forehead. That's to say, for brow presentation. Okay? These three movements of flexion extension occur on the vertical axis of the fetal head. However, the atlanto-occipital joint can act on the transverse axis. So, if the fetal head is tilted to one side, the condition is called asynclitism and results in two types of cephalic presentation: the anteroparietal bone presentation and posteroparietal bone presentation. And here the denominator is the parietal bone. So we have 5 types of cephalic presentations according to the fetal head attitude. We have vertex with full flexion, face full extension, brow midway between flexion and extension, anterior parietal bone presentation, and the posterior parietal bone presentation when the head is tilted to the side. We come to the breech. If the fetus presents with its buttock with the 2 feet and the attitude is complete flexion, this is called complete breech. Incomplete breech means there is complete flexion of the whole joint of the pelvis. The knee is flexed, the hip is flexed, the ankle is flexed. This is complete flexion. Unlike encephalic presentation, complete flexion attitude of the head is the most common presentation, which is the vertex presentation. While in breech, complete breech or complete flexion of the breech is not the common. Okay, you should remember that. The second type, when the legs are extended in front of the fetus, so the hip joints are flexed, but the knee and ankle are extended, so the presenting part is just the buttocks, so it is frank breech, and this is the most common type of breech presentation. And according to the flexion extension movement of the lower limb, it may be knee presentation, footling, single or double footling presentation in breech presentation. The shoulder presentation occurs when the lie is transverse and the dominator of the shoulder is the scapula. Okay? This figures represent the three types of presentation. In figure 1, this is cephalic presentation. Figure 2 is complete breech presentation, and 3 is shoulder presentation. We come to the fetal position. What is meant by fetal position? The long spoon of the fetus is its back, and so we try to identify the position of the fetal back in relation to the anterior abdominal wall of the mother. For this purpose, the fetal back may be toward the anterior aspect of the anterior abdominal wall, may be right, may be left, or may be posterior. We have 4 standard positions. In the first standard position, the back is anterior and to the left. In the second standard position, the back is anterior, and to the right. The third standard position, the back is posterior and to the right. And the last, fourth standard position, the back is posterior and to the left. This will be understood well when we discuss the umbilical grip for detection of the fetal position. These are examples of the 4 standard positions. We come to an important item, which is the fetal head engagement, the engagement of the fetal part. Engagement means the passage of the widest transverse diameter of the presenting part below the plane of fetal of the pelvic inlet. So we have 2 items to be known: the widest transverse diameter of the fetal presenting part and the plane of the fetal of the pelvic inlet. We start with the widest transverse diameter of the presenting part. We have 2 types of presentation that may be engaged: the cephalic and the breech, while the third, which is the shoulder presentation, it is not deliverable, cannot be engaged. And so the widest transverse diameter of all cephalic presentation, and for the third time, for all cephalic presentations, is the biparietal diameter, except when there is asynclitism. The widest transverse diameter in cases of asynclitism is subparieto-supraparietal diameter. So the widest transverse diameter of all cephalic presentations except in asynclitism is 9.5 centimeter, which is the biparietal diameter. If in asynclitism, it is subparieto-supraparietal, and it is only 9 centimeters. When the presentation is breech, the widest transverse diameter is the intertrochanteric diameter, the diameter between the 2 trochanters of the fetal pelvis, and it is 10 centimeters. Okay. The second item is the plane of the pelvic inlet. The plane of the pelvic inlet is that plane passes through the following point from posterior forward: the sacral promontory, the alum of the sacrum, sacral promontory lined with the red line, ala of the sacrum lined assigned with green color, the sacroiliac joint, the iliopectineal line with iliopectineal eminence on it, the upper border of the superior pubic ramus, pubic crest, and the upper border of the symphysis pubis to the contralateral parts on the other side. This is the plane of the pelvic inlet. This plane of the pelvic inlet is not horizontal. However, it makes an angle with the horizon. This angle is 55 degrees. So it is inclinated. It is inclinated, and this facilitates the process of labor. This facilitates the process of labor and may explain the movement of internal rotation during normal labor. Okay, so you know now what's meant by engagement. We shift to how to diagnose engagement. How can we diagnose engagement? Engagement can be diagnosed by one of two methods, whether abdominal method or by vaginal method. Abdominal method was described by Creston. Depending on the amount of the fetal head, which amount of the fetal head can be felt abdominally. Accordingly, the head may be floating above the brim if the whole head is felt easily by abdominal examination. If only 4/5 of the fetal head can be felt by abdominal examination, it is fixing. If only 3/5, it is not engaged. If it is only 2/5 can be felt abdominally, it is engaging, just engaged, or engaging. If only 1/5 is felt abdominally, it is engaged head. If nothing of the fetal head can be felt abdominally, it is deeply engaged. And this is the abdominal or Creston method. The second method is the vaginal method, in which the zero station or the landmark for calculation is the ischial spine. Ischial spine is considered as station 0. Engagement begins when the lowermost bony part of the fetal head is felt at the level of the ischial spine. Stations of the fetal head are assigned by positive or negative according to their distance from the ischial spine. If the distance of the lowermost bony part of the fetal head is 1 centimeter below the ischial spine, it is station +1. If it is above the level of the ischial spine by 1 centimeter, it is station -1. Again, engagement starts when the fetal lowermost bony part of the fetal head is at station 0 or more. Okay? Okay. Let us see the following figure. Here we examine the lady with our index and middle finger by vaginal examination. The index assigns the position of the lowermost bony part of the fetal head, and the middle finger assigns the ischial spine to correlate the position. Finally, what is the most accurate method for diagnosis of engagement? The most accurate method is the obliteration of the retropubic space by the fetal head. Here, the station according to delay is +3 or more, and so this is the most accurate or the most pathognomonic method for diagnosing fetal head engagement. We come to the last two items, which are the complications. Complications of the current pregnancy are either pregnancy induced, such as some disease that cannot be found except in pregnant women, as preeclampsia eclampsia syndrome, antepartum hemorrhage, premature rupture of fetal membranes, fetal malformations, fetal death, RH isomerization, and so on. The second item is pregnancy aggravated. So let's say this patient is sick and has some disease, chronic disease, and this disease is worsened by the occurrence of pregnancy, such as rheumatic heart disease, systemic lupus erythematosus, hypertension, diabetes, and so on. The past history of disease or previous disease or surgical procedures that may affect the management of current pregnancy should be asked for and should be mentioned. Examples: diabetes mellitus, maternal cardiac disease, fibroid, some surgical operations such as cesarean section, myomectomy, and so on. Here we completed the items, including the definitions of the complete obstetrical diagnosis. Complete obstetrical diagnosis. Again, obstetrical diagnosis consists of gravidity, parity, duration of pregnancy, fetal lie, fetal presentation, fetal position, fetal head engagement, complication of the current disease, of the current pregnancy, whether medical or surgical, previous complications that may affect the management of the current pregnancy. I will give you an example how to formulate the obstetrical diagnosis. This patient, Mrs. X, she is pregnant. This pregnancy is the fourth pregnancy. The duration of pregnancy is 36 weeks. She is pregnant with a single fetus, which is living fetus. She had two previous deliveries, only two previous deliveries, and one abortion. The first delivery was by vaginal route, and the second delivery was by cesarean section. She had rheumatic heart disease. How to formulate the obstetrical diagnosis of this patient? We start with gravity and parity. Also, okay. What is gravidity here? Is fourth gravida. Okay. Parity. She had two deliveries, so she is second para. Okay. Okay. The third item is duration of pregnancy. She is 36 weeks of pregnancy. So she is fourth gravida, second para, pregnant 36 weeks. What about the fetal lie? The fetal lie is longitudinal lie, because he mentioned that the head faces the pelvic inlet and the back is anterior and to the left side of the abdomen, maternal abdomen. So she is fourth gravida, second para, pregnant 36 weeks, longitudinal lie, cephalic presentation, left anterior position. What about the disease, maternal disease, rheumatic heart disease? What about surgical procedure, previous cesarean section? So, fourth gravida, second para, pregnant 36 weeks, longitudinal lie, cephalic presentation, left anterior position, non-engaged head, rheumatic heart disease, previous cesarean section. This is how to formulate the obstetric diagnosis. We shift to the requirement to obtain this obstetric diagnosis. The requirement or the procedures are history taking, and a clinical physical examination, and lastly, urine examination for protein and sugar. We start with the history taking. History taking, as any branch of medicine for a female, we start with personal history. Personal history here must be started in an obstetric case with gravity and parity, with gravity and parity, with gravity and parity, and because this is the first item to be mentioned in the sheet. Okay, so we can say prime gravida named, aged, but you should start with gravity and parity. Complaint, menstrual history, obstetric history, past history, family history, and finally the present history. We start with personal history, starting with gravity and parity. Then we should ask for the patient name, and you should call the patient with her name. Ask for date of birth to calculate her age, the address, urban, rural. This may affect your management if she high risk pregnancy. Job, some jobs, in some jobs, she is prone for severe exercise or environmental contaminations. Textile factories, the patient working in textile factories are more liable for asthma. In marital status, the patient, married or not, her husband has another wife or not, number of living children, to evaluate how precious this baby, special habits of medical importance, especially smoking. The husband history should be asked for, and this may reflect the socioeconomic status and may explain some recurrent infections in the patient if he has another wife, and so on. Example of the personal history: prime gravida nullipara named Nada Ahmed Mahfouz, 23 years old, from Al Gala Street, Dumyat, teacher, married since November 20th, 2018, with no special habits of medical importance. The husband's name is Muhammad Ahmad Ali, 32 years old, carpenter and cigarette smoker. We shift to the complaint. Here is a special situation. The patient is pregnant, and so the first complaint in any pregnant woman is being pregnant. So we start the complaint by the following phrase: cessation of menstruation since the last normal menstrual period, which started at whatever date. Okay, if she does not know the first day of the last normal menstrual period, we can say cessation of menstruation 8 months ago, 7 months ago, and so on. Then we ask for the presenting complaint. Let's say the complaint that brings her to hospital or to our outpatient clinic. The main complaint. If there is more than one complaint, you should arrange them chronologically or according to their importance from the patient point of view. This is a module for the complaints of a pregnant patient with the last normal menstrual period started as July 25th, 2019, and she came to hospital because of antepartum hemorrhage. We start the complaint as follows: cessation of menstruation since the last normal menstrual period, which started at July 25th, 2019, passage of blood per vagina 2 days ago. We shift to the menstrual history. Menstrual history includes the following 8 items: menarche, which is the first day of the first menses in the woman's life. Then the cycle rhythm, which is regular or irregular, the cycle length, which is the duration from the first day of the menses to the first day of the next menses. The normal cycle length ranges from 3 to 5 weeks. Then duration of menstrual flow, the period of shedding menstrual blood, it ranges from 2 days to 8 days, the normal. Then the character of menstrual flow according to the amount, the color, the odor. Then association of the flow with pain. The term is dysmenorrhea. Dysmenorrhea is painful menstruation, pain related to menstruation that affects the daily routine of the lady. If it does not interrupt the daily routine of the lady and it is tolerable by the patient, it is not a dysmenorrhea. It is menstrual molemina. And then we should ask about the intermenstrual period if it had pain, abnormal pain, or bleeding or discharge. However, there is normal intermenstrual pain, which is called ovulation pain or Mittelschmerz pain. This pain is explained by the localized irritation of the peritoneum by the follicular fluid that's released with ovulation, because this follicular fluid contains many chemicals including prostaglandin. Or normal intermenstrual discharge due to the effect of high levels of estrogen was called ovulation cascade. And lastly, May had intermenstrual spotting, which results from transient decrease in the maternal hormone due to, as a result of ovulation. Okay. The last item is the date of the last normal menstrual period. Here is a model for menstrual history. Menarche at 13 years, of course. Cycles were regular, recurring every month. Menstrual flow was of average amount, lasting for 5 days. Dark red in color and no specific odor, the ordinary odor. No associated dysmenorrhea. Intermenstrual period were free from pain, bleeding, or discharge. The last normal menstrual period was at December 12th, 2018. Expected date of delivery at 19th of September 2090. We come to the obstetric history. Obstetric history is quite different from the obstetric diagnosis. The obstetric diagnosis is the ultimate goal, the ultimate objective of our lecture. Obstetric diagnosis is one item of the history. It includes gravidity and parity, full-term normal deliveries. By full-term normal deliveries, we mean normal labors. What is the definition of normal labor or the definition of full-term normal delivery? It is spontaneous expulsion of single, living, not dead, viable 37 weeks or more fetus presented by the vertex, full flexion attitude, presented by the vertex through the natural birth canal, vaginal, within a reasonable time from 3 hours to 24 hours, without aid except for episiotomy or pitocin, without complication to the fetus or the mother. And this is the full-term normal delivery or the normal labor. Preterm labors, those pregnancies that had been terminated with a gestational age between 20 weeks and 36 weeks plus 6 days. Let's say before 37 weeks. Stillbirth, delivery of dead fetus. Whether this death occurred in utero or intrapartum, delivery of dead fetus is called stillbirth. And so this fetus must be more than 20 week gestation. If the fetus is dead before 20 week gestation, it is missed abortion. It is missed abortion. Okay? Difficult labors are those vaginal deliveries that are lacking the criteria of normal labor. Vaginal deliveries that are lacking the criteria of normal labor. That is to say, for example, if it is forceps delivery, not spontaneous, it is difficult labor. If the delivery of more than one fetus, it is not single, so it is difficult labor. If it presents with the breech, it is a difficult labor, and so on. Cesarean deliveries should be asked for. Cesarean delivery is the delivery of a fetus or fetuses with an abdominal and uterine incision after 20th week of gestation. Okay. Then we ask for abortions. Abortions are pregnancies that had been terminated before 20th week gestation. It may be first trimester abortion or second trimester abortion. We ask for the number of abortions, type of abortion, how it starts, and how it terminated. Last delivery date should be asked for, and last abortion date. We ask for previous pregnancy complications, especially those which tend to be recurrent, such as preeclampsia, Rh isoimmunization, and so on. Periperia is the period of time following delivery or abortion. Following delivery, it is 4 to 6 weeks duration. Following abortion, according to the type of abortion, whether first trimester or 2 weeks following first trimester abortion. If it is second trimester, about 4 to 6 weeks duration. Here we should mention, this is a place to mention these terms. Early pregnancy means gestational age less than 8 weeks. First trimester abortion from 1 to 14 weeks. Second from 14 to 28 weeks. And third from 28 to 42 weeks. Medical legal viability is a legal term. It is of no medical importance. It is in the Egyptian law 28 weeks. Differs in other countries and other laws. Obstetric viability is 37 weeks, the beginning of term. It means that when the fetus is born after that date or that age, gestational age, it can live unassisted extrauterine life. Term pregnancy is that with gestational age 38 to 42 weeks. Past history. The following items should be asked in the past history. Past history of similar condition. Past history of medical disease such as diabetes mellitus, hypertension, bilharziosis, tuberculosis, irradiation, drug sensitivity. Past history of surgical operations. The nature and date of the operation should be determined. Past history of gynecological operations, the nature and the date of the operation should be determined. Past history of contraception, if closely related to pregnancy, for example, pregnancy on top of IUD. Family history of hereditary disease such as diabetes mellitus, hypertension, chromosomal anomalies, family history of familial non-hereditary disease such as diseases that are in common socioeconomic status, such as rheumatic heart disease, tuberculosis, and then family history of similar condition, family history of general condition, of similar conditions such as preeclampsia, twin pregnancy. Twinning should be asked for the mother, for the pregnant woman and her husband, because if the husband had a twin pregnancy, twin sister or twin brother, his wife may had twins. We come finally to the present history. Until we see you in part 2 of obstetric case taking, I wish all the best for you. Thank you very much for listening, and